Good afternoon, everybody. I'm Dr. Sachidanand, Vice Chancellor, Rajiv Gandhi University of Health Sciences, Bangalore, welcoming you all for this online training program being conducted by Rajiv Gandhi University of Health Sciences on behalf of Government of Karnataka in this pandemic, COVID pandemic. Today's program is the 52nd program in a series of online training program that RGHS has organized. This program has been appreciated by not only the Honorable Chief Minister of Karnataka, but also he made it known to the Prime Minister office also that we are almost touching around 1 lakh people online, which is by itself is a very Herculean task. It was very necessary right from the day ago when lockdown was declared that we had to do something about capacity building of our healthcare professionals, be it a doctor, be it a nurse, or an allied health science professional. So that was the challenge that we faced, and we took it up. And very effectively, we have been doing this program of training all the healthcare professionals involved in the COVID-19 treatment, and we have been successful so far. And in that series, today's program is the 52nd program. And for your information, we have been able to uh, train everybody belonging to each and varied section of the doctor's profession, like pediatricians, obstetricians, psychiatrists, public health expert, pathologists, microbiologists, you name it, everybody were trained here, and there was a tremendous response. In fact, when the feedback was given to us, many healthcare workers mentioned that the training that they received during RGHS online training program helped them to face the situation that they were in actually in the field. So that was a very positive uh, response, plus encouragement for us to go on with this. So with that thing, today we have a topic, uh, training of doctors on convalescent plasma therapy for COVID-19. As you all know that we do not have any specified or a specific treatment for COVID. Whatever drugs we are using are all empirical, but there have been some anecdotal reports that they have worked in some cases, and in some studies they have been retributed. But whatever it may be, logically, we can think that plasma therapy is a more a logical thing than a theoretical possibility, which has been proved. It's not a new thing that in COVID-19 only we are trying to introduce this. It has been there earlier. It is as simple as understanding that a person who has recovered from COVID-19 infection would have developed immunity and would have antibodies in his blood, which is which is drawn, concentrated, and then given to at least two or three other beneficiaries, which would definitely boost the immunity in the persons and the recipients, and then probably help him combat the disease in a better way. That's what is the whole concept about. But the nitty-gritties of all this, of this convalescent plasma therapy, would be discussed by the experts here today. I welcome all of you for this online training program, and thank you well in advance for sparing your time and expertise. I'm sure the doctors who are waiting for your lectures to be heard will benefit at the end of the day by the whole program, and we'll have a lot of doubts being clarified and a lot of take-home messages as well. So I welcome Dr. Srilata, Professor and Head Department of Immunohematology and Blood Transfusion at BMCRI Bangalore. She would be speaking on why convalescent plasma therapy in COVID-19. Dr. Harsha, Assistant Professor, Department of Microbiology, BMCRI, Antibody Testing in Convalescent Plasma Therapy, COVID-19. Dr. Anita, Assistant Professor of Biochemistry in BMCRI, Biochemical Investigations in Convalescent Plasma Therapy, COVID-19. And Dr. Sita Lakshmi, Professor in the Department of Transfusion Medicine at St. John's Medical College on donor eligibility and convalescent plasma collection. And of course, at the end of the session, there would be a panel discussion and question answers would be taken. You could shoot your questions through the chat box that you have on your devices, and the questions would be answered. If there are some of you who have missed this program, you could convey the message that this whole program will be recorded and available on YouTube. Anybody can download and see it at their leisure. even friends who have not been able to log in can see it later on. So that is the advantage of this program. And without wasting much time, I would ask Dr. Srilata, Professor in the Department of Immunohematology and Blood Transfusion, to take over and conduct the proceedings. Thank you, ma'am. First slide.
At the outset, I would like to thank the RGHS organizers for giving us the opportunity to speak on why the convalescent plasma, which has been very much in news, that we have to know that why at all is it really necessary to start with the convalescent plasma therapy or not. So I'm from the Bangalore Medical College. So I'll be speaking on is it necessary to start with the convalescent plasma therapy. As we all know that in the history, it's not that we are starting it as a new thing, that it is something like the old wine in a new container. So according to this, the history that it has been started from 1918 itself in H1N1 influenza pandemic, and in various pandemic virus outbreaks. So we have been using this the convalescent plasma in Ebola virus in the year 2014, and the Middle East respiratory syndrome in 2015, and various other pandemics also we have been using this. So, and now the new container is nothing but we are all facing it. That's the coronavirus, which has become the pandemic, and it is the severe acute respiratory syndrome, the coronavirus 2. That's what we are facing, and it's been a complete new pathogen, to say that with no vaccine and monoclonal antibodies are the drug available. So in this situation, what one should do? Should we go about with the convalescent plasma or no? This is what we are going to come to the conclusion at the final end. So now to begin with, the US, it was during March 24th, 2020, the US FDA was approved for the convalescent plasma therapy, and from there onwards it became very important to know that whether we have to join for this convalescent plasma study or not. So this it focused on the advanced study of the plasmapheresis, the plasma source, and in this that is a recovered individual who is eligible to donate the blood, and prior to that he should have had this the COVID-19 document which has been positive, and then after he has been the symptoms have been resolution after the 14th day prior to the donation is been taken into consideration, and female donors who are negative for the HLA antibody and male donors have been chosen for this study. And in the end, finally, it was observed that the results, that is the negative results for COVID-19, either from one or more nasopharyngeal swab specimen or for molecular diagnostic test was chosen. And finally, the eligible criteria, as it has been concluded, it's been told in any study for that matter, whether it is from for the advanced study or for the initial phase studies, the criteria remains the same. So, and then why in this COVID-19 is a important aspect. So in this why means, this is the picture which depicts, it is a simple, very simple procedure wherein a recovered patient who is of COVID-19 patient who is recovered, a sample of it, a very small amount out of the 6.6 to 6.5 ml of liters of the blood. Only a small amount of the blood has been taken from, the blood which gets centrifuged, and that has been collected, and it will be transferred, which are rich in very virus neutralizing antibody, which will be transformed in a manner for the prophylaxis manner or for the therapeutic way. So this picture, it depicts whether at the cellular level, how it acts, at what level does it act, the convalescent plasma. So here to look at this picture, so it works at the receptor level itself, whereas the other drugs, it gets involved, it gets actioned up at the internal organelle level. So that's the difference between the convalescent plasma and the other drugs what has been used right now. A few articles which have been very specific, very specifying the usage of the convalescent plasma in the COVID-19 has been noticed. To begin with, in a very short time, it is the JAMA that has been come up with the study, and the articles has been put up. Though it has been very few cases, it helps us a lot to know how and where we are with that of the convalescent plasma. So in this study, just 5 to 10 of the patients have been studied. So the other cases also where the sera against the coronavirus, that is in SARS-1 in 2003 and the MERS in 2012 also been studied, in which the analysis was found that 90% had neutralizing antibody with the genomic mean titer of 1:61, and titer declined with that of the time. So this shows how it has been utilized and how it is helpful for the persons who have been suffering with that disease. So the Chinese also, they studied and the Shenhan study who has done on the critical ill patients who have been diagnosed with the COVID-19. So the disease severity had been classified with that of the respiratory failure, which showed that there is a requiring mechanical ventilation, and the shock which was identified by the use of the vasopressin therapy and elevated lactate levels, which with adequate fluid resuscitation, and failure of the other organs which were requiring administration of ICU. All these things, the results were seen to be that there was improvement, a drastic improvement in the patient's clinical status. So this is a very important slide wherein the various authors, they show that within a short time how they have been improving with the clinical manifestations. That is, there is an increase in the partial oxygen pressure and all these things, the decrease in the viral load within 12 days, and there is increase in the SARS-CoV-2 specific, and then the neutralizing antibody titers. There is a resolution of ERDS within 12 days, and there's a mechanical ventilation got weaned up within 14 days, and the patient got discharged within within the days of 51 to 55 days in 3 of the cases. So in Duan et al., the study, it shows that the clinical symptoms were significantly not there within, got down within 3 days, and there was all these things was noticed. The image, the clinical imaging, it showed varying degrees of absorption of the lung lesions within 7 days. And Zhang et al, he also found out that the same way they also experienced the same improvement in all the COVID patients. So not only in this, even in the Ebola cases, this plasma study was, plasma therapeutical intervention was done, and they have seen a lot of improvement in this case also. So these were now, the ICMR has also been given us, everyone, all of us, task to go about and study with that of the convalescent plasma therapy or the COVID patients, so that it helps in getting up the large amount of the data. So it helps us to know how it is useful. So these are the methods and the outcomes and all these things which it indicates. So this is again a study of the 10 cases, which shows which was started in February 9th and 8th, and the titers which were of this 1:160 and all these things, by the end of the study it showed that they are all negative. So you can see how improvement it has been seen by the intervention of this convalescent plasma. So not all, I mean, like any other drugs, even this has got some pros and cons. So we have to look for its pros also, which have been very much important at this time of intervention therapy. So this is which can be used for prophylaxis of infection or treatment of the disease. Therapeutically, it can be administered to those with clinical disease in an effect to reduce their symptoms and mortality. And in prevention and prophylaxis, it prevents infection and subsequent disease in high-risk people, such as vulnerable individuals with underlying medical conditions, the healthcare providers, and those with exposed to confirmed cases of COVID-19. So the risk factors, as we all know, like any other transfusion, here also we can, if it is not taken care properly, we can expect the hypersensitivity reaction, also the type 3 antibody dependent enhancement for the infection and attenuation of the humoral immunity, leading to chances of reinfection. So all these things can also be seen, noticed, which can be taken proper care otherwise. So what is that Indian scenario? Where are we in this Indian scenario in this aspect of the convalescent plasma? Is the availability of centers for establishing the anti-COVID immunoglobulin levels of recovered patient. That's the most difficult task which we have to start at the very early stage, at an early level, starting from the patient's entry into the hospitalization. We have to motivate them. That is the one big task each one of us should take up. And the full-fledged transfusion medicine specialist is established in established tertiary centers for obtaining the convalescent plasma should be there. That's what I felt. And then well-trained the healthcare professionals for transfusing and assessment of patients undergoing plasma transfusion. That's also is a must. And but there is at present there is no DCGI approval for conducting the investigational new drug trial based on the convalescent plasma therapy. This is where we are in India. But the points to ponder, what we have to take the message is, as there is no single drug strategy for proving the effectiveness of the drug as a drug of choice for the COVID-19, one has to think whether this has to be taken or not in a serious way. All drugs at present which have been supportive, which might be steroids or retroviral or the anti-malarial or anti-inflammatory, they're all supportive. And where does this convalescent plasma stands? This is also a supportive, no doubt in it. and the supplementary, which has been essential. And throughout, it has been tested in a few pandemics, starting from early 1918 onwards, and it has been observed that there is no change in the clinical manifestation, or there is a complete fast recovery of the patient and getting discharged in a much faster rate. So the whole world now, as a pandemic disease is this also has been become a pandemic way of studying, and it is an opening. It is an opening and an opinion for studying the pros and cons of it. And when the study has been done in a large scale, one can reach to the conclusion about its action in different provinces and with the varied genetic capabilities of its acceptance by the en masse of the population. As we know that each drug, whether it might be now the reason of late, even the Ayurveda, they say, yes, we have come up with the anti-COVID-19, and the homeopathy, they say, yes, we have come up with that. So we do not know for which person which will act. So in that way, I think it is appropriate that we should go ahead and then start treating and take a chance, and then promote and encourage this convalescent plasma therapy. It's a self-satisfaction. One should find, as today, that many of us, we are in the asymptomatic stage, and even if in future, if we ourselves have to be in that stage, how should we react? Whether we have to accept it, and whether we have to go ahead with that donation, plasma donation, or not. Yes, we have to. Otherwise, it's at least it's a good thing that we are saving at least 3 of the patients when the aliquots are being done with 200 ml to 200 and 100 ml. At least 3 of the persons can be saved. That satisfaction will be there. And of course, along, if we are the regular donors, along with that, we'll have many more benefits to our own body. It is a noble chance to save others' life, as the person who has already suffered knows about the preciousness of the life to his family members and also to the society by saving at least 3 lives. So it's a simple procedure. One has to remember, one need not worry, yes, giving out plasma, it is such a big procedure. It's a very simple procedure which Madam Sita Lakshmi will be taking in much in detail. And the side effects, if it is used in an appropriate way, it is less when compared to any other drugs, as it is a very natural therapy. Why one should go ahead with this therapy is to reduce the risk of getting COVID in high-risk populations like the healthcare workers, Anganwadis, and other, which can be restricted on going for this quarantine time also. So the trials were being shown successful in treatment of the SARS, MERS, H1N1 in earlier studies, and vaccines to reach out to the en masse public is time consuming. By that time, passive therapy by using the converted plasma therapy can be used for the time being. And one more thing, what I want to tell is there is one more, means a concentrated one, that is a hyperimmune IVIG immunoglobulin, which is when compared to that of this, which is a cost effectiveness. So this can be utilized in a much better way. That's what I feel. Even the mesenchymal cell therapy also has come up, whereas both of these are of cost-effective procedures and time-consuming. So in that way, the CPT can be utilized. So this is the another one right now. We can all the people, we are going by, instead of going and asking for become a voluntary donors to save lives. Now that new concept has come up, donate plasma and save lives. We have come to this state, and this is that logo of it. So this is another very small picture which depicts mythological picture which depicts wherein here we all know that it's a small animal. Even this wants to help to build up the bridge from India to Sri Lanka during this Ramayana. So Rama says, yes, please go ahead. So it's a gap filling. It's a gap filling. So for that, even this small creature, it got its value by getting this 3 lines, a beautiful 3 lines which has been remembered. So that's what is this therapy also depicts. Though it is small, it has its own value in filling up and giving the benefits to the person who is suffering. So that's what is the final, we have to think whether we have to proceed forward or not. It's left for us, and it's time. Why not, when the whole world is going ahead with the utility of the convalescent plasma therapy, why not the India also? So in that aspect, yes, it is time to act. We should come friend and donate the plasma for the benefit of ourselves and as well as for the others. Thank you so much for your patient hearing.
Presentation.
Good afternoon to all. This is Dr. Harsha from BMC. In Sapalauda. Okay. Okay. So I will be speaking a role of antibody testing in convalescent plasma therapy. So we have already started the convalescent plasma therapy and we are yet to start testing for the antibodies. So is it really essential or is it really important to test for the antibodies before doing the convalescent plasma therapy? So what is the necessity of antibody testing? So why antibody testing? So as we all know, most of the infections are either mild or asymptomatic. So even those people who are asymptomatic and mild infections, even they will develop antibodies. So antibody test helps to determine whether or not someone was previously infected, even if that person never showed symptoms. So you may not be, we may be positive for the viruses, so you may not be tested, but we will be having antibody. So the antibodies testing helps us to know the presence of antibodies, even though we never showed symptoms. So our body produces antibodies against multiple antigens. It's not just against single antigens. So our body develops antibodies against various antigens. So not all the antigens will be immunogenic. Not all the antibodies produced will be effective. So only those antibodies called the neutralizing antibodies, only these neutralizing antibodies will be effective in containing the infections. So what is the neutralizing antibodies? How does it differ? Usually whenever the virus enters into our body, as you can see in this picture, it first binds to the receptor surface on the epithelial surface, then it enters into the cell by a process of endocytosis, and then it fuses with the endosomes and gets uncoated. So what if there is an antibody? The antibody is usually, if it is neutralizing antibody, it binds to the receptor binding domain of the receptors on the virus surface. So this blocks the attachment. Either it blocks the attachment into the epithelial surface, or the antibodies can also block the entry of the viruses into the cell by blocking the endocytosis, or it prevents the binding with the endosomes. So the antibodies, either they can prevent the binding, or they can prevent the entry of the entry into the cells, or they can prevent the uncoating. So these antibodies, if they are present in sufficient quantity, they block all these pathways, thereby preventing the infection. This is one more picture which demonstrates. Here there is a, here the antibodies are bound to the receptor binding surfaces on the SARS-CoV-2. Here in the SARS-CoV-2, it is the spike protein. It is a spike protein, which is a receptor binding domain, which the antibodies binds to. So whatever the titers, is it sufficient if the antibodies are just present in the blood? The antibodies must be present at least only 160 of the titers. So right now we are not testing it for it. So what we can do is we can test once the antibody testing appears. We usually do rely on the IgM and IgG ELISA based antibodies test. So these ELISA based IgM and IgG antibody tests have got greater than 95% specificity for the diagnosis of COVID-19. So so when the antibodies are produced, as you can see in this graph, usually it takes 14 days or 2 weeks for the antibodies to develop. So the RT-PCR becomes positive even before the onset of symptoms. As you can see, 1 week before the onset of symptoms, RT-PCR will be positive. So the antibodies will begin to produce only after 1 week after the onset of symptoms. So initially the antibodies produced will be IgM, later the IgG takes over. So this is the purple color, this is the IgM antibodies. The half-life of IgM is very limited. Once the IgG takes over, the concentration of IgM decreases and IgG usually stays for a longer time. So actually the presence of neutralizing antibodies can only be confirmed by a plaque reduction neutralization test. So since this test is very rare and very cumbersome and time intensive, we don't do usually plaque reduction neutralization test. Usually we rely on the enzyme based immunoassay test to check the neutralizing antibodies. So how long does the SARS-CoV-2 antibodies stick around? How long do they present after the infection? We still don't know. Still, they say only 2 to 3 weeks the antibodies will be present. So the best time to donate the plasma is between the 2 to 3 weeks after the infections. After the 3 to 4 weeks, we do not know whether the antibodies will still be present in the blood or not. So the antibodies, the plasma, they not just contain the antibodies, they also contain other immunomodulatory effects. That means, you can see in this picture, the convalescent plasma, apart from containing the neutralizing antibodies, they also contains anti-inflammatory cytokines and the antibodies which blocks the activation of the complement system and also the autoantibodies. So the convalescent plasma has both effects. The one is the antiviral effects by the neutralizing antibodies and also by the other neutralization of the cytokines, which plays an important role in cytokine storm, and also the anti-complementary antibodies and also anti-autoantibodies. So both the antiviral effects and the immunomodulatory effects will result in the containing of the infection. So what are the limitations in the antibody testing? So we still do not have quantitative serological assay, which is not yet defined, is not yet widely available to identify the donors with high titer neutralizing antibodies, and we are not sure about whether the person might be recovered from the disease, and we will not show the consistency in the antibody titers and consistency of the viral neutralization activity in plasma between the donors. Next slide. ಇಲ್ಲ ಇನ್ನೊಂದು ಸ್ಲೈಡ್ ಇದೆ ಅದರಲ್ಲೇ
ಇದರಲ್ಲೇನಾ ಯಾವುದು
ನೆಕ್ಸ್ಟ್ ಲಾಸ್ಟ್
ಇದೆನಾ
So in convalescent plasma therapy, what is the risk involved? As we are, apart from the transmission related complications like infections, we have one more entity called antibody dependent enhancement. So what is this antibody dependent enhancement? Usually, as we all know, as I talked about the antibodies, the neutralizing antibodies, what it does, it usually blocks the binding of the virus particle into the epithelial surface. Suppose if the antibody is of low quality, if the antibodies are non-neutralizing antibody, or if the antibody titer is low, or if there is any cross-reacting antibodies, what they can do is they can, despite blocking they can actually facilitate the entry of virions. Instead of blocking the entry into the site of attachment, these blocking antibodies they actually facilitate by binding to the FC receptor on the macrophages. So instead of stopping the blocking chain or the continuation of the virions, these virus can gain entry into the cells and they actually increase the infection rate. So this antibody dependent enhancement, as it's been seen in, explained very well in the dengue infections, says there will be cross-reacting antibody, or if even the titer will be low, then also the ADE can occur, or even the antibodies, or if it is non-neutralizing antibodies, then also the antibody dependent enhancement can occur. So in the antibody dependent enhancement, instead of the virus entry blockage, the virus gains entry into the cell and increases the infection rate. Thank you.
ನೆಕ್ಸ್ಟ್ ಅಲ್ಲೇ ಕೂತ್ಕೊಳ್ಳಿ. ಪ್ರೆಸೆಂಟೇಷನ್ ಯಾವ್ದು ಹೇಳಿ?
ರೋಲ್ ಆಫ್ ಆಂಟಿಬಾಡಿ.
ಈಗ ಕೊಟ್ಟಿದ್ದಾರೆ.
ಇಲ್ಲ ಪ್ರೆಸೆಂಟೇಷನ್ ಮಾಡಿ.
ಪ್ರೆಸೆಂಟೇಷನ್ ಒಂದಾ? ಅಲ್ಲಿ ನೋಡ್ಕೊಳ್ಳಿ. ಎಷ್ಟು ಬಟನ್ ತೆಕ್ಕೊಳ್ಳಿ ಒಂದ್ಸರಿ.
Good afternoon, everyone. First of all, I would like to thank our Vice Chancellor, Dr. Sachidanand sir, for giving me an opportunity to speak on this forum regarding this biochemical investigations in convalescent plasma therapy COVID-19. I am Dr. Anita, Assistant Professor from Department of Biochemistry, BMCRA. As you all aware, coronavirus disease is abbreviated as COVID-19, is a global pandemic caused by severe acute respiratory syndrome, coronavirus 2. What is the role of laboratory in COVID-19? As the number of individuals infected with COVID-19 continues to rise globally, healthcare systems become increasingly stressed. It is clear that the clinical laboratory will play an essential role in this crisis, contributing to the patient's screening, diagnosis, treatment, monitoring, and more importantly, epidemiologic survey as well as the recovery. Now, where this laboratory role comes into picture is, once the patient is infected with the SARS-CoV virus 2, the disease will set in and either he'll manifest the death or the recovery. As we all know, diagnosis is made by RT-PCR. So what is the staging all about? So our biochemical laboratory comes into picture here based on to stage the disease for the prognosis of the patient and for the therapeutic monitoring. What is the staging all about? It is mainly for the treatment, where we stage the patient as green zone, orange zone, or the red zone based on the symptoms. So what are the biochemical investigations in COVID-19? Actually, this was already done in the previous webinar. Eminent speakers have spoken about this. So only I'll brief about little bit on this biochemical investigations. Recommended test list is based on the current scenario, is included below along with the major laboratory abnormalities associated with the COVID-19 patients and their potential indications. So what are the routine parameters we do in this is plasma glucose, serum urea, creatinine, then liver function test, electrolytes. What are the special parameters that we do? Serum ferritin, C-reactive protein, lactate dehydrogenase, troponin I. So along with this, we also have, in addition to more common laboratory tests, new evidence suggests that these COVID-19 patients could be at the risk of cytokine storm syndrome. So cytokine test, particularly interleukin 6, should be used to assess in patients of suspected hyperinflammation. So these are the investigations we have seen that is raised. So based on the multi-organ failure, each analytes will be raised. So if the patient is in ICU or hypoxia, there will be deranged blood gases. So if liver failure sets in, decreased albumin and raised in the aminotransferases, then pulmonary damage and severe inflammation, systemic inflammation indicates raise in lactate dehydrogenase. Then renal failure tells us about raise in urea creatinine. Then cardiac injury tells us about the, in cardiac injury there is raise in cardiac troponin. Then when there is superimposed bacterial infection, procalcitonin will be raised. Apart from this, we have acute phase reactants and the inflammatory markers like C-reactive protein as well as the ferritin. So especially in viremia or viral infection, hyperferritinemia will be seen. So hyperferritinemia is a clinching feature of viral infection. And C-reactive protein is an acute phase protein that is released in respect to the cytokine storm. So cytokine storm, interleukin 6 will be assessed. In considerations for the pediatric age group, recent studies recommends that clinicians monitor lymphocyte count, C-reactive protein and also procalcitonin to assess the sepsis. Along with that, we have interleukin 6 to be investigated as a potential pediatric prognostic indicator. Clinicians recommend all these investigations for the progression of the illness and also for the assessment of the sepsis in infants as well as children. All of us are talking about this cytokine storm. So in brief, I would like to tell what is this cytokine storm. So whenever this virus enters the body's host cell, what does it do? It replicates, okay, and it is released into the circulation. So once this is released into the circulation, it activates all the cells of the body. It has the affinity for ACE2 receptors of the lungs. So because of which the macrophages, dendritic cells, epithelial cells, antigen presenting cells all get activated and they release these cytokines into the circulation. So because of these cytokines, what is happening, both the cellular immunity as well as the humoral immunity of the host is being decreased. So the host inflammatory response against the infections is characterized by the release of pro-inflammatory cytokines and acute phase proteins, driving both innate as well as the adaptive arms of the immune response. Interleukin 6 can also suppressive functions of the regular T cells and prevent the T helper cells from converting it into regular T cells, illustrating a pivotal role of interleukin 6. See, in very low levels, interleukin 6 has a protective effect. But what happens in this cytokine storm? Many cytokines, it includes interleukins, interferons, as well as the chemokines, which are released in maximum levels into the bloodstream, because of which the cytokine storm is setting and the patient adult respiratory distress syndrome sets in for the patient. What are this pro-inflammatory cytokines? So once from this macrophages, as we have seen, there are many n number of cytokines. So these include tumor necrosis factor, interleukin 1 beta, interleukin 6, interleukin 18, interleukin 1 beta. All these, they have various systemic inflammations. So it acts on the blood vessels where vasodilatation and vascular leakage is seen. So interleukins, mainly they have the affinity towards the leukocytes, causing leukocytosis. Then all these interleukins act on the liver to release the acute phase proteins like C-reactive protein as well as the ferritin. On the hypothalamus, these cytokines cause fever and the hyperalgesia. So the cytokines or the interleukins or the cytokine storm, which we are all reading now, release the acute phase proteins into the circulation, causing systemic inflammation where there is hyperinflammation of this particular cytokine storm. So the cytokine storm, as we are aware, it affects the clotting coagulation cascade, lung injury, immune paralysis seen, renal failure, then cell death might occur, shock because of severe infection, organ failure, as well as the inflammation. The patient might expire or death will be seen in such patients. Now coming to C-reactive protein, it is an acute phase protein of hepatic origin that increases following the interleukin 6 secretion by the macrophages as well as the T cells. It is raised in the inflammatory conditions. Then ferritin, it has as I told you, it is a very important acute phase protein. It is an indicator of the viral load in the person. So it is an intracellular storage form of iron. It stores iron in a non-toxic form and prevents iron from catalyzing radical formation, thus protecting the free radical damage to the lipids, proteins as well as the DNAs. It also reduces the cytotoxicity of iron and increases its solubility. It turns out that elevated ferritin concentrations are associated with an increased production of special signaling molecules which can lead to the complications and death of a person. Now coming to special parameters like troponin I, troponin T and LDH. So once the patient sets in, so myocarditis, once the patient is infected with coronavirus 2, so myocarditis will be seen. So troponin I explains the damage to the cardiomyocytes in response to coronaviral infection. Troponin I is specific as compared to troponin T because troponin I has only one isoform, whereas troponin T, now called as high sensitive troponin T, is also equally important in assessing the myocarditis. Lactate dehydrogenase also explains the severe inflammation of the COVID-19 disease. Now, in regarding to this, I would like to just share previously. Just a few things about the experience of Innova Hospital with respect to these ferritin as well as the C-reactive protein. So when the, according to this, as I told you all, green zone is when the patient walks in asymptomatic. We do the regular investigations along with ferritin as well as the C-reactive protein. After 5 days of admission, or if little bit symptoms sets in, so we go for routine investigations, C-reactive proteins, electrolytes, ferritin, along with that troponin I or T. And if the patient has gone into severe, if the patient is responding for the second sample, if the patient is in orange zone and if he's not responding, if the ferritin levels even increase, then we assess the interleukin 6. Whereas procalcitonin is assessed in patients with whom superimposed bacterial infection is being suspected. This is the protocol we are following in our hospital. Now coming to convalescent plasma therapy. So convalescent plasma, what is it? It is the therapy that involves the use of antibodies from the blood of the patients who have recovered from COVID-19 to treat the infected patients. So India's CDSCO has permitted ICMR to conduct a clinical trial of convalescent plasma for the treatment of COVID-19. Then CDSCO further noted that convalescent plasma was historically used in viral diseases such as poliomyelitis, measles, mumps, influenza, and even before the vaccines were developed. This therapy is being used in pandemics where the treatment protocol is not specific. As you all are aware, convalescent plasma is derived from the recently recovered patients with neutralizing antibody titers above 1:640 was transferred to the patients as an addition to the maximum supportive care and the antiviral agents. So actually this again madam will be dealing at it, and it is already told infected person. Okay, he's been treated. Okay, a little bit plasma will be collected and it can be either for the prophylaxis or the therapy. So madam will be dealing in detail about this procedure. Then coming to the investigations for the donor selection prior to the plasmapheresis. So what are we supposed to do? So serum calcium is being done mainly because while doing the plasmapheresis, a patient might throw into tetany because of decreased calcium. So for that, serum calcium is being assessed. Serum electrolytes and serum total protein along with albumin tells us about the liver function test of the donor. Urea creatinine tells us about the renal function, kidney function of the donor. Then along with that, CBC as well as the antibody titer, which includes IgG and the neutralizing antibody titers in the donor sample. Now, once the sample is being collected, we transfuse the plasma into the recipient. So what are the investigations that we do in the recipient? Pre-transfusion, we do the routine investigations along with that CRP, serum ferritin as well as the lactate dehydrogenase, and in turn interleukin 6 depending on the symptoms of the patient. So post-transfusion, routine investigations along with that CRP, serum ferritin and the lactate dehydrogenase. So post-transfusion investigations will be repeated on the 3rd, 5th and the 7th days to know the response of the transfusion. So what are the effects of the CP transfusion? Mainly improvement of the clinical symptoms, reduction of the pulmonary lesions on the chest CT examinations, immunomodulation via amelioration of severe inflammatory response. Then we have amelioration of the routine laboratory criteria and the pulmonary function, and increase of the neutralizing antibody titers and the disappearance of the COVID-2 RNA. This is very, very important. So the CP used in the treatment has shown that a large quantity of neutralizing antibodies capable of neutralizing SARS-CoV, eradicating the pathogen from the blood circulation and the tissues. So because of this, what is happening? The serum SARS-CoV RNA negativity after CP transfusion, then improvement of the systemic inflammation due to the complement activation. This is important, as Dr. Harsha said. Complement activators also will be there in the plasma. Then increase of the oxygen saturation, increase in the lymphocyte count. Then apart from this, because of improvement in the immunity of the recipient, we can see the improvement of the liver function. It can be assessed by the level of the aminotransferases. Then decrease in the CRP, decrease in the LDH and decrease in the serum ferritin levels, in turn decreasing the systemic inflammation due to free radical damage. To summarize, biochemical investigations play a vital role to assess the severity of the infection and the inflammation. It also helps in the prognosis of the patient, especially IL-6 and the procalcitonin, in turn to plan the treatment protocol. So conclusion includes the occurrence and the development of the SARS-CoV-2 depend on the interaction between the virus and the individual's immune system. So viral factors include virus type, mutation, viral load, viral titers and the viability of the virus in vitro. The individual's immune system factors include genetics, age, gender, nutritional status, neuroendocrine immune regulation and the physical status. All these factors contribute whether an individual is infected with the virus, the duration and the severity of the disease and the reinfection. In the early stages of the epidemic, accurate diagnosis helps control the spread of the disease. It is imperative to develop new, safe, accurate, fast, simple, new laboratory technologies for detecting SARS-CoV-2. These are my references and thank you for patience hearing. Before ending this my talk, I would like to thank my professor and head, Dr. H.L. Vishwanath, Department of Biochemistry, BMCRI, for giving me an opportunity to speak in this forum. And also I would like to thank Dr. Srilata for guiding me in this talk. And I would like to thank all my senior professors and colleagues in my department. Thank you for patience listening.
ఇదేనా
50 బ్యాగులు తెప్పించుకుంటారు. ఐసీఎంఆర్ పర్మిషన్ ఇవ్వడానికి పర్మిషన్ ఇవ్వాలి కదా. 50 బ్యాగులు కలెక్ట్ చేసి పెట్టుకుంటాం. తర్వాత ఏం చేస్తాం? మామూలు పేషెంట్ పెట్టి ఇవ్వాలి. అవును ట్రాన్స్మిషన్ సిలిండర్ మరి మీకు ఈ పేషెంట్లు అడుగుతారు సార్ ఇంకా ఎక్స్పెరిమెంటల్ స్టేజ్ లో ఉంది. బేసిక్ ట్రయల్ చేయాలి చేయడానికి మనం ఇంప్రూవ్ చేస్తాం. ఐసీఎంఆర్ చేస్తుంది ట్రయల్ అది ఇంప్రూవ్ చేస్తే
Good afternoon. I would be discussing on the role of donor selection and collection of plasma for the treatment of patients suffering from COVID-19. But before we decide on the mode of therapy, it's very important that we understand the pathology of the disease. And like all my colleagues, the other panelists have spoken, they have discussed in depth what is this that the infection causes. So we have understood that there is something called a cytokine storm, which results in hypotension, vasodilatation, ARDS, and pulmonary edema. We also realize that there is an abnormal activation of the coagulation process, results in thrombi in the circulation and tissue hypoperfusion. There is an abnormal inflammatory response resulting in pulmonary edema and ARDS, and at the same time, endothelial activation contributes to the pathology of the disease. So having understood the pathology of the disease, we now discuss what are the treatment options available. Again, like everybody has shared, it's by and large supportive therapy. We know that there are antiviral therapy, there is anti-malarial, role of steroids, and of course, interleukin-6 inhibitors, which were talked about just now. Now, what is the role of convalescent plasma therapy? As we understand, right now it is only an experimental role, and the basis behind is immunological. Now, when we talk about convalescent plasma therapy, all of us should remember that the antibody that is there in the patient who is recovering from the disease, it's a passive administration of antibody from somebody who is recovering. And when we fractionate blood products, we get hyperimmune globulin, monoclonal antibodies, and vaccines, and these are meant to give durable therapeutic options. And of course, in the context of COVID-19, they are not yet available, and that is why human plasma is the only therapeutic strategy that is available in an experimental option at this point of time. So when we talk about immune plasma collected from individuals, what is its role? Its role, as I discussed earlier, is only a short-term benefit. It can prevent infection or it can blunt clinical severity in those who have been recently exposed to the pathogen. Passive antibody therapy is most effective when administered prophylactically or even used early after the onset of symptoms. The clinical benefit, the radiological resolution, reduction in viral load, and improved survival are some of these aspects that have been documented in literature. Globally, yes, we have several blood centers that have an excellent infrastructure to undertake plasma collections and also build up an inventory to meet the growing demand. There are, of course, challenges. What challenges? Logistical issues of collection, transfusion. Besides this, it's not yet under the regulatory purview. So it's very important that we choose donors appropriately. So the donor eligibility criteria, donor recruitment should be very stringent so that there is no misuse and appropriate use is being taken care of. Now, when we talk about the role of convalescent plasma, as I just discussed, there are a range of indications. I mentioned that it can be used prophylactically or also in patients who are already suffering from the disease. It's also important to look at the patient population, age, associated comorbid diseases, and so on, which is definitely going to influence the way an individual responds to this treatment. We did discuss a lot about the role of antibody, and therefore I'm not going to talk much about it at this point of time. Now, besides passive immunity, are there other benefits? Is something that we should keep in mind. It's patients are also going to develop polyclonal antibodies that are present in the convalescent plasma, and this is going to help in those individuals who have humoral immune deficiencies. Besides this, because plasma is rich in clotting factors, it can help in managing hemorrhagic diathesis like we see in other viral infections, and to a limited extent maybe in COVID-19 infection. So this flow chart is essentially going to show us what are the different sources of plasma. One is whole blood. So can we use whole blood to treat these patients? It's a question. But now, today, in a world where we are almost 100% component therapy, most centers will resort to using plasma rather than whole blood. How do we get this plasma? Plasma can be collected from a donor's blood, where you collect about 450 ml of blood and separate from that 450 ml 200 ml of plasma. But a more effective use is collecting plasma by apheresis, where you only use the collect plasma and return the red cells and platelets back into the donor's circulation. So this is called apheresis, where we selectively remove one particular product. So plasma pheresis is the best option in this situation. Of course, component therapy in centers who do not have a facility for apheresis, can they still give convalescent plasma? Yes, they can collect whole blood, separate the blood into components and use the plasma for treatment. So you're going to ask me one important question at this stage. What happens to the donor's red cells? So is this red cell going to be of use to anybody? I'm afraid not, because you've collected red cell from somebody who has recently recovered from a viral infection, and therefore it will not fulfill the qualifications of donor eligibility for preparing red cells. So it cannot be like a healthy individual's red cells, and therefore that cannot be used. So even in a center where apheresis facility is not available and somebody badly needs to give plasma, one could consider it as a last option. So I spoke about convalescent whole blood. Yes, in those days, maybe a century ago, when component therapy was not yet there, convalescent whole blood was given during Ebola virus outbreak. But today, we would prefer plasma therapy because it ensures larger volume collection, more frequent donations, and it does not cause unnecessary anemia in the donor. There are several benefits of plasma therapy. One is to remove the inflammatory cytokine. Two is to stabilize the endothelial membrane, and very importantly, reset the hypercoagulable state. Another important factor is that the same donor can go through multiple cycles of plasma pheresis procedure and therefore become a repeated donor for this patient, for any patient. Now, how do these antibodies act? These antibodies can bind to the pathogen. You saw the diagram in the previous lecture that was given, where it causes neutralization and inhibits the infectivity of the organism. Now, besides binding to the pathogen, it can also cause complement activation, antibody-dependent cellular cytotoxicity, and phagocytosis. We also know that there are several non-neutralizing antibodies that can bind to the pathogen and contribute to the enhanced recovery of these patients. Now, if somebody wants to facilitate convalescent plasma therapy, how does one go about it? Now, the first thing that we could consider is an emergency use. Madam briefly spoke about investigation new drug, the IND application. So one could approach this mechanism of having to access convalescent plasma therapy for a patient as an emergency. Now, this allows a provider to apply for compassionate use in an individual patient who has life-threatening disease and there are no other options available. This guidance does not allow for prophylaxis. The minimal requirements enable those requests to be expedited. And this is what happened to one such situation in our country, where they explored this as a last option and we got to hear that the patient has recovered. Now, what is the second modality that we could resort? That is to apply for a research, like a part of a clinical trial, which any organization can do. The third thing is a government-led initiative. That is what has currently happened in India, where ICMR has come out with a protocol, and this facilitates, you can get a large number of institutions to participate under this protocol, and therefore you can get extensive data which can be used for future studies. So if you're looking at a clinical trial, it starts with an institutional ethical committee approval. It's very important to register in the clinical trial registry. And of course, the DCGI approval is mandatory. Now, when we talk about donors, who is eligible to donate? Everybody who has had COVID-19 in the past, can they donate is a question. Definitely there are some criteria. So those who are aged above 18 and the age requirements are as per the Drugs and Cosmetics Act. So one has to fulfill the regular criteria of blood donation. Male donors definitely yes, but female donors, it's important that if they are multiparous, we should remember that the chances of them acquiring anti-HLA antibodies are very high. Therefore, it's preferred to have a nulliparous woman. But if you want to choose a multiparous lady, we have to demonstrate the absence of anti-HLA antibodies. So prior diagnosis of COVID-19 documented by RT-PCR with symptomatic disease, complete resolution at least 28 days prior to donation, or complete resolution of symptoms at least 14 days prior to donation with 2 negative RT-PCR tests from nasopharyngeal swab collected at least 24 hours apart. So these are the minimum criteria. They should have had a past history of COVID. They should have been RT-PCR positive. They should have had complete resolution of symptoms, and we should have 2 negative RT-PCR tests for COVID-19 24 hours apart after 14 days of resolution in order to become eligible to donate plasma. Please note that the viral shedding in survivors have been documented as long as 37 days. And that is why it becomes mandatory that they have to be tested and shown that they are RT-PCR negative. And with regard to the appearance of antibodies, it was beautifully illustrated in the graphic representation in the session on antibodies, where we understood that IgM and IgA antibody develop very early as day 5 after the symptom onset, but IgG takes longer to appear on day 14, and they are universally detected on, suppose you test somebody on day 20, most of them will have. That is why it's optimal to collect plasma after 2 weeks, maybe in the 3rd or the 4th week is the best time to collect plasma. As I mentioned earlier, I would like to stress the fact that donor eligibility criteria for regular blood donation should be followed in accordance to the Drugs and Cosmetics Act, which was amended early this year in March 2020. So we all are very familiar as blood bankers. A donor selection form is there. So it's mandatory that they fulfill all those criteria. They also have to fulfill the criteria that I spoke about as defined for selection of plasma donors for convalescent plasma therapy, and that is where testing for COVID-19 initially positive, then 2 negative tests tested 24 hours apart after 14 days of complete resolution all become very, very important. Now, when we are screening the donors, of course, physical examination is very important, and donors are not fit to donate if you have a history, a positive history or examination. You're going to exclude them. Those donors who've had recent blood transfusion are definitely going to be deferred. Donors who've had COVID-19 diagnosis more than 4 months prior will also be excluded, because like it was discussed in the previous session, it is known that these antibodies are going to wane away with time. So we are not even sure whether after 4 months after the disease, the antibodies are still going to persist in their circulation. Therefore, it may not be appropriate. So what are the tests that one is going to do? Of course, ABO and RH group is essential and mandatory. It's important to do an antibody screen, a complete blood count, platelet count, hemoglobin, very important, a total and a differential white blood cell count. Donor's hemoglobin should be greater than 12.5, platelet count more than 1.5 lakhs, and total WBC count within normal limits. It's very important to test them for all the transfusion transmissible infections that we are all well aware of, including syphilis and malaria. Test for serum protein. So the plasma protein level should be greater than 6 gram per deciliter. Presence of IgG and IgM antibodies by the appropriate kits that may become available soon. Otherwise, it's important to preserve the plasma and maybe test it subsequently. Now, looking at titration of antibodies, that was also mentioned in the previous session. The desired titers for IgG antibody is 1 in 1024, and for neutralizing antibody, at least 1 in 40. So if not done, like I just mentioned, at the time of plasma collection, we could store the donor sample at -80 degrees to be tested subsequently as and when we have test kits available. Another important aspect that we cannot afford to forget is the donor consent. So the donors have to be explained about the procedure, including the adverse events that may be associated, and consenting for donation is absolutely important. Now, moving on to plasma collection. What does plasma collection involve? Of course, any center which decides to conduct this procedure for their patients definitely have to have an apheresis facility, that is a cell separator equipment with adequate space and trained manpower, SOP, the availability of disposable kits, and of course, license for plasmapheresis is very important. So there are several equipments available in the market which can do plasmapheresis as well as plasma exchange. I'm going to be focusing on plasmapheresis. The plasma collection is done by centrifugal separation by any apheresis equipment that may be available in that particular blood bank. The volume collected in each setting should not exceed 500 ml, and this is as per the Drugs and Cosmetics Act. Remember that the extracorporeal volume of blood should not exceed 15% of the total blood volume of that individual. So many of us who are doing apheresis routinely will agree with me that it's mandatory that based on the height and weight of the donor, we calculate the blood volume, and that will help us decide how much blood volume is processed per cycle, and we also ensure that the extracorporeal volume does not exceed 15%. Donor adverse events should be managed as per protocol. Now, how do we store these plasma? The collected plasma can be divided into aliquots. When I told you 500 ml is collected, it can be separated into two 200 ml aliquots and 100 ml aliquot. And where do we store this plasma? At -40 degrees Celsius. And remember that as of now, cooling of plasma from different donors is not permitted at this point of time. And by and large, centers opt for this therapy are usually using it as a product as of now, because there is a patient who really requires, there is a donor who is eligible to donate. All that they do is collect and transfuse immediately. So at this point of time, we have not reached a stage where we've been storing plasmas to be used at a later date. We should also remember that what will happen to the antibody titer by repeated freeze-thaw cycle. Now, usually when a plasma is frozen, it can be thawed only once and transfused immediately. So repeat freeze-thaw cycles are definitely not allowed. But even with a single freeze-thaw cycle, is it going to affect the quantity and function of the immunoglobulin is a big question. But as of now, there is no evidence to say that this single freeze-thaw cycle is going to affect the quantity and function of the immunoglobulin. Now, when a donor donates successfully, can he come back to this procedure again? Yes, a donor can come back for repeat procedure at least 2 weeks after the first plasma donation. But we have to ensure that there is no loss of red cells at any point of time. If for some procedural error or some other technical issue, there has been a red cell loss, then the donor will have to be deferred for the next 3 to 4 months, depending on whether the individual is a male or a lady donor respectively. And as I said, all the donor selection guidelines have to be applied even in the setting of repeat donations. So now in repeat plasmapheresis, it's very important to measure total serum protein and document it. The quantity of plasma separated from the from the donor should not exceed 500 ml per setting, and remember that it should not exceed 1000 ml per month. So in effect, he cannot undergo this procedure more than twice a month. can there be any donor-related adverse events? Yes, the donor can have adverse events which are common to any apheresis procedures. They could have local reactions, they could have systemic reactions. It could be mild, it could be severe. So they can be a hypotensive reaction, which is very rare in an apheresis because the volume collected is not very high. Citrate reactions can occur in some individuals. That's why we give calcium for them. Madam explained very well that the procedure can deplete an of calcium. Hematoma formation is quite common. The other complications are quite uncommon. Now, there could be kit or equipment related adverse events. There could be air embolism, leakage, improper mounting of the kit, a common issue, and chances of infection, very, very rare. Now, when we talk about plasma infusion, we have already collected, we have prepared, we have stored. Now, next point is to infuse the plasma. So, this is how the apheresis setup will look. You see the plasma is collected and infused. The clinician will obviously have to send a request for plasma component. What is the difference between a request for a routine plasma and in this setting? He has to specifically mention the diagnosis and he has to specifically ask for convalescent plasma. It's important that we ensure ABO compatibility of the unit, and thawing should happen at 37 degrees and it should be transfused within 2 hours. Standard SOP for transfusion of FFP should be followed, and special care to monitor the patient during transfusion and 24 hours, up to 24 hours post transfusion is very important. All transfusions must be obviously done using blood transfusion sets. Now, what is the dose that is optimal? There are several studies that have been conducted. We are not yet sure what is the optimal dose. As I mentioned earlier, one dose of 200 ml convalescent plasma is considered the first dose. Now, if this first dose has not led to any adverse event, there could be a second dose that is considered, which can be transfused after 24 hours after the first dose. Therefore, the cumulative dose for each patient becomes 400 ml. Now, when we choose a second unit, the second plasma unit may be preferably chosen from a different donor depending of availability of another ABO compatible plasma, or else the same donor's plasma could be issued. How do we respond? How do we assess the response to treatment? Of course, clinical evidences are there, radiological evidences are there. There are several other surrogate endpoints. One thing that we could monitor is the antibody titer rise. So the recipient plasma should demonstrate an increase in the antibody titer and a drop in the viral load. Whenever PCR testing is not possible to just monitor response to treatment, one can look at cycle thresholds, value of which will increase when the viral load decreases. There are several variables that are associated with this procedure. As I mentioned, the dose itself is variable. Literature talks about as small a dose of 200 ml and as high a dose of 2400 ml. Antibody titers, you all will agree with me, is very, very variable. Day of transfusion has also ranged from day 6 to even day 50. Viral load decrease has been demonstrated even day 1 after transfusion and even as late as day 30 after transfusion. So a lot of studies are being conducted and a lot more information is coming every day. With every day, a lot more additional information is coming. But these are all some of the variables. We don't really have an answer to many of them. I told you about adverse events related to the donor. Do we have adverse events related to the? Yes, definitely. Adverse events are possible, but we are glad that most of the time it's medically treatable and non-lethal. But to remember that there are some adverse events associated with plasma like TRALI, transfusion associated circulatory overload. You can have a simple allergic reaction at the same time. In certain rare situations, you can have a severe anaphylactic reaction to plasma proteins. Transfusion transmissible infections, yes, which applies to any other transfusion. Febrile non-hemolytic transfusion reaction are all possible. And this concept of antibody dependent enhancement has also been talked about. So we've spoken about convalescent plasma as therapy, but in a rare situation, it can facilitate the viral entry into the individual. But of course, this is as of now only a theoretical concern. It has not been proven in the context of COVID-19 as of today. Yeah, now I just want to draw your attention to an interesting fact. I'm sure many of you have read. What is the association with SARS-CoV-2 infection and blood group? So it has been documented that blood group A individuals are more prone. Okay, so the natural isoagglutinins found in plasma of group O and group B. Obviously, group B individual will have anti-A antibody. Similarly, group O individuals will have anti-A and anti-B antibody. Now, this naturally occurring anti-A antibody has an effect, has a beneficiary effect. A group individuals have only anti-B antibody and therefore they are more prone to the viral infection. So there is enough literature which talks about it. So I would encourage some of you to go back and look at it more in detail. So it's been shown that the odds ratio of acquiring COVID-19 is higher in blood group A than in blood group O. COVID-19 has more severe clinical presentations in elders and in males. And we all know very well, as one grows older, there is a reduction in the antibody levels. So this could be one contributing factor. So studies are hence ongoing to evaluate the correlation between isoagglutinin titers and outcomes in blood group O and B patients. So while preserving ABO match compatibility, so when I was talking to you earlier, I said it's important to give ABO matched plasma. Blood group O and B donors may be preferred in this context because they have anti-A antibody in the plasma, and also, if possible, to look at the titers of anti-A isoagglutinins. It would be interesting for us to study more about this. So this is just the workflow that we spoke about, the inclusion and exclusion criteria that is involved in the ICMR trial, which involves a control arm and an intervention arm. And the intervention arm is the one that we are talking about, the convalescent plasma therapy, and the control arm where there is a usual standard of care for any COVID-19 patient. And ma'am was just talking about follow-up of these patients. So the study protocol also involves follow-up at day 1, 3, 5, 7, and so on to ensure to monitor the progress of the disease. So what I have essentially talked about is how plasma therapy can help, what is the mechanism of action, how does one select a donor, what is the care that a blood banker has to take, what is the basic infrastructure required, what are the options that are available to us, is it only apheresis, can we use component therapy when there is no apheresis facility, and what are the benefits of plasma therapy and plasma exchange in a nutshell, and can the procedure be repeated, how often a donor can donate, is all that we discussed about. And my sincere thanks to all of you for the patient hearing. Thanks to the Rajiv Gandhi University of Health Sciences for giving us this opportunity, and thanks to the panel members for sharing this forum with me. Thank you all.
Questions is there? Chat box will have to get.
Yeah. So I would like to request the delegates who are listening to us now, if there are questions, kindly type it in the chat box so that if we are able to answer some of them, we could discuss it right now. Thank you.
Presentation ಮುಗಿತಲ್ಲ.
You can read out.
Just again, ನೀವು ಹೇಳ್ತವ್ರು.
There are multiple strains of COVID-19. Will the neutralizing antibody have a uniform efficacy across all strains? No, they because of variations in antigen nature, even the antibodies will not be effective against the neutralizing antibodies. No, the answer is no.
Any other questions?
Should we check for viral load in plasma donor? No, usually the plasma donor will contain the antibodies and not the viruses. The viral load will be very, very less. There is no viral load at all.
Can I clarify?
Yeah, please.
Yeah. It is, in order to be eligible for plasma donation, it's important to prove that they are RT-PCR negative for COVID-19 on 2 occasions, 24 hours apart, after minimum 14 days of recovery. So that is one of the required criteria to fulfill. So you must first show that they were RT-PCR test positive for COVID-19. After 14 days, minimum 14 days period should be there, and you should have 2 negative tests to be eligible for donation. So that is the required criteria. After administration, what should be the increment in titer of antibody to demonstrate? Yeah, this is a little difficult question to answer. As I told you, there are several variables. Now, as of today, the antibody titer quantification itself is not yet, we are not yet ready for that. There are no commercially available kits as of today, nor has it been defined what is the minimum antibody, although theoretically it is there. The immune responses of individuals are so different. As I said, the ideal would be to have neutralizing antibody titers greater than 1 in 1048. But we may not, we are yet to evolve. And right now, yes, this antibody titer after recovery, there are not enough studies to say that this should be the minimum increment. This is one of the methods of monitoring the response to patients. Suppose this antibody titer was 0, and you are able to demonstrate antibody in the circulation, that itself will reflect that the patient is probably improving. So that is one of the parameters that you could monitor when you assess response to therapy.
But however, the ICMR has given a standard titer.
Yeah, not for monitoring. They have only said
For the trial basis. For the trial basis.
Yeah, for recovery, yes.
6.
We already answered that. Plasmapheresis is not available. Just a minute, let me read the question.
Is your question saying not on?
Sir?
The question saying not.
There was one question there. How much of the treatment decision will be guided by this increment? As of now, as I mentioned, that increment levels itself is not yet, optimal increment is not yet decided. So we cannot, the treatment decision is not based on one factor alone. There are multiple factors which would contribute to the treatment decision. So at this point of time, we don't have that answer ready. So there was another question about, that is not seen, sir. About that plasma.
For that reason only the trials are happening in a very
Yes.
elaborative way to fix that one.
Some of the questions are not necessary here. Yes, there is one question saying, is there any chance of residual virus remaining in the plasma? Yes, there is literature to say that there has been viremia demonstrated after more than 1 to 1.5 months. Yes, there is chance. There is also that during recovery that, viral shredding continues to happen. So there is definitely a chance, and that's why it's important for us to test by RT-PCR and demonstrate that it is negative before selecting the donor. Yes. How many cases of, where is that? Yeah. Multiple, yeah. Is prophylactic, it's jumping. Is prophylactic CP therapy being used in India? Not as we have, none of us have encountered. Yes, in the US
they are doing it, not here.
Yeah.
We are in the phase 1 and phase 2 study.
Is there any chance of residual that we spoke about? How many cases of plasma therapy done in your center till now? Madam, would you want to say anything? In your center, you've
In our
started doing?
center, one study has
Okay.
been done.
So, ma'am, you can,
No, you can talk.
yeah, you can talk.
One study has been done at our center. Trial phase 1 has been done.
Are there any serological markers to determine need to repeat transfusion, or is it determined by clinical response only? In terms of serological markers for repeat transfusion, as I mentioned earlier, a donor can come for the second donation 15 days after the first donation. And ideally, as of today, we are not yet testing the antibody levels. We are only assuming that he has antibody. He has recovered from the disease. We are proving that they are RT-PCR negative. As of today, antibody tests are not yet in vogue. We hope that the tests will come soon, in which case we will be able to incorporate. That is over. That's also
10
over.
questions.
Is there any chance that is also over? How many cases done? That's also over. Yes. Are there any serological markers over? Are viral inactivation techniques being considered for residual viral risk? Yes, there are viral inactivation techniques, definitely. Yes. Like any other plasma product, viral inactivation techniques are definitely an option that we could consider depending on the facilities available at our center. But it's not yet mandatory in India. Am I right?
Yes.
Yeah.
UV rays,
Yeah.
we use it.
Yes. Is there a probability of a recipient producing an anti-convalescent serum antibody? Yes, if somebody is recovering from the disease, definitely there is a possibility that the recipient could develop his own antibody. Definitely. So like we saw in the graphic representation that was there in that session, in the normal course, if an individual is recovering from the disease, yes, 14 days in the second week, IgG antibodies start appearing and they peak by 3rd to 4th week. They're well demonstrated. So definitely, yes, recipient, if immune system is functional and good and there is an adequate immune response, they are expected to develop their own antibody. So the basic purpose of plasma therapy is that it offers passive immunization to tide over the crisis. So by that time, the recipient or the patient himself starts developing his own antibody. That's why, as I mentioned, it's only a temporary cure. It's a short lasting, unlike immunoglobulins and vaccines, which are going to offer a long-term therapy. Yeah, I hope I've been able to answer this question. Yes.
That's all.
Yeah.
How is the prognosis?
How is the prognosis in plasma-treated patient? Now, the prognosis is multifactorial. Patient with COVID-19 infection may or may not have several other comorbidities. So those are the factors which will influence the prognosis. It's not just by one line of treatment alone that will decide the prognosis. But as I mentioned, one should be very cautious of the adverse events that are specifically associated with plasma therapy. Like I said, the simple allergic response, anaphylactic response in an extreme case, those are risks associated with plasma transfusion. So one should be aware of them. The trolley, the taco, and all of this should be, one should be careful and watch for them. That is why it's important to monitor these patients during and 24 hours, up to 24 hours post-transfusion, so that we know that there is no adverse event associated with plasma therapy.
It also depends upon at what stage this convalescent therapy has been implemented, whether it's in a moderate state or in the severe state. If it is in a very severe state, naturally it will become triggered to the other systems to go ahead for the multi-organ failure.
Yeah. So the stage of the disease is another important factor.
And associated disease of the patient also. If is already having a
Other comorbidities.
suppressive thing.
Yeah. Okay. So thank you all for the patient hearing. I think sir will.
Thank you, madam. I'm sure all the participants have benefited. I'm standing in for the Honorable Vice Chancellor, who is currently preoccupied with another meeting. I take this opportunity to thank Dr. Srilata, Dr. Harsha, Dr. Anita, and Dr. Sita Lakshmi for their wonderful inputs. I'm sure in this evolving situation, every bit of knowledge added and every bit of new knowledge that a professional is made aware of will come in handy to handle the situation better. I'm sure that all of you who have been a part of this program would go ahead and confidently handle the situation using the knowledge that has been provided. This being the 52nd in the series of training programs conducted by Rajiv Gandhi University of Health Sciences, wherein we have reached out to more than 70,000 attendees. I'm sure with the help of professionals as we have with us today, we will be able to take control of the situation and rise to the occasion. Thank you very much all for your participation and wish you all the best. Please stay safe. Thank you.